the thing. Supposedly, we're going to have quite a few visitors in lab today. I've had a lot of students from my other sections basically want to reschedule their labs for tonight, so we might have some people to accommodate today. So we'll see if that pans out or not. I'm expecting them, but we'll see if they actually show. Shouldn't be a long lab either way. But, everybody settled. When saying Kaylee, Julazy, and CLO. did not mean to do that. Helpful. Smaller, I don't want smaller. Let's go ahead and get going. So chapter 17, once again, just one more reminder that as we are studying, your goal is to be able to explain all of these learning objectives back to me without having to refer to notes, right? So that's the goal, just one more reminder as we're going on with this. We know next Tuesday is the exam. So unit 3 exam is going to be normal place, normal time for that, FYI. So keep that in mind. It'll be during this time next Tuesday for that. So that'll be next Tuesday. The Tuesday after that, we will start with our presentations. So keep in mind that your presentations will actually be due on the 16th, which is 12 days away. So if you haven't started them, go ahead and start them. Don't think anybody in this class has submitted any presentations for me to review, just FYI. So again, if you haven't submitted yours, you're not behind. No, but I don't think anybody in this class has submitted any. But keep that in mind that if you do want me to review it, get it to me like 2 days before the due date so that I can get back to you with feedback and make sure that it's all kosher. And if you want to do a recording of your presentation, you must submit it with your slides at the due date time, not on your presentation day. If you want to present in person, then all that is due is the slides. But again, if I only get slides when you turn it in, I'm assuming you're presenting in person and there's no take backsies on that. So be aware of that. It's your choice if you want to present in person or do a recording for that stuff. If you believe that your recording will convey that you learned about your disease well enough, then that's great. I hope that you're right. But if I watch it and I think it was scripted, then I'm going to ask you questions in class. Again, I'm not going to be super judicious about this, okay? I'm not trying to be like making this hard, but I do want you to put effort in. That's what I want to see, okay? So just FYI. So if I just, yes.
Still let us know if recordings aren't up to par.
Absolutely, yes. So if you record it, yes. So if you record it ahead of time, I will watch your recordings. So I've already had some of my online students submit recordings and I've watched them. I'm like, this is good enough, man. This is good enough. And I'll let you know if it's not. And if I think this is too scripted, I will say so in the comments, if you get it to me with enough time to review it. That's the benefit of that. Yes, okay? Well, absolutely, anything. I want to set you up to get full 100% on this. That's what I want to set you up for. So FYI, that's all. So we know we're doing for unit 3. We're focusing on unit 3, study for that. As we move into unit 4, I won't be lecturing those days. We will just be having presentations during unit 4. There'll be presentations if we have time, which we probably will because we don't have a full class. So if we have time after the presentations, we'll do some Kahoots together to fill that time up to make sure we're covering the lecture content. Because again, your guys' presentations aren't going to cover all of the diseases in the chapter. So we'll do some Kahoots. It won't be lecture Kahoots. It'll be like our old Kahoots. And we'll walk through them and stuff like that for our Kahoots after we do the presentations for that day. And like I said, we'll try to fit all of everybody's presentations on the Monday after the exam and the December date after that. So we're not having presentations, hopefully, during Thanksgiving week. Remember how we discussed that. Remember during Thanksgiving week, when we would be having our lab exam on Tuesday, we're hopefully going to be rescheduling it. And so you have to sign up for that. And I'll send out another reminder for that. If you haven't signed up for a day or a time for the lab final, which would be Thanksgiving week, I have the time set where you can either join my Monday class morning. I'm having a Monday night one at 5 p.m. So if you can make that one, sign up for that one, or Tuesday morning one. So that way we don't have to come in on Tuesday night of Thanksgiving week. So I think we all would appreciate that. So you can sign up for that and I will send another, I'll just send the same announcement back out again. So if you haven't done it yet, that's okay. I'll probably do that right after our unit 3 exam. So no rushes on that, but just a reminder about it. So if you have a preference, then you can sign up for it on that. Any questions about that stuff as we're coming up to it? Yeah, it'll have your name, like you have to sign up with your name on it. So it'll have your name on there still, whatever. Again, I have plenty of slots for Monday night. So I think most of us will be signing up for Monday night. So if you want to come on Monday night, should be I can accommodate everybody on Monday night. So yeah. This Thursday, I will have a review over chapter 17 and 18 that we're lecturing on today. So I have a review on Thursday for that. And then on Sunday at 4 p.m., we'll have our usual like Kahoot playthrough game play. If you haven't done the playthrough gameplay for Kahoot for Unit 1 and 2, it's the same thing that I do for Unit 1 and 2. Again, it's the Kahoot that I will play through, and I cover whatever questions people are missing. People are getting a 50, like the average is 50% or less on a question. Then I talk about that content. I record it all. Well, I say record it. I write it down on a notepad as I'm doing it. And then I will paste it in the announcement. That's what that thing was last time for Unit 2, where I was like, here's some topics that we cover in the review. It was that stuff. The questions that people were missing a lot of on the Kahoot games. So I do cover that stuff during the Kahoot game. I don't record the Kahoot game itself, but I'll make notes and I will post the notes for it. So if you can make it to that, that'll be at 4 p.m. on Sunday. Otherwise, the same link, same as usual. I'll post the link so you can play it on your own time if you want to. But yeah, pretty straightforward stuff there. I don't think this applies to anybody. It doesn't apply to anybody's class, but FYI, if somebody were watching this as a recording later on, or we're joining from another class or something like that, if somebody has a D at this point in the class, if you had a D in the class right now, it is unlikely that unless you do something drastically different to do better on the test, that you will get a C in the class at this point. Unlikely if you had a D right now. Is it impossible? Absolutely not. Like you could definitely get a C if you step up your studying and actually do something different. But again, if somebody has a D at this point in the class and they're doing the same thing that they've been doing the whole time, it's very unlikely that I see Ds go up at this point. So that's why I just want to bring that up. If you have a C, you could still go down to a D. That's possible, but you could also still go up to a B. There's still room for pretty much everybody to wiggle within a letter grade of their grade, depending on what you're doing. If you're doing the same thing, it's likely that you're going to keep the same grade. If you're doing something more, something different, something better, maybe it'll go up. I'm not making any promises though, right? That's on you at that point. So FYI, I'm saying this because what is Friday? The last day to drop the class. So FYI, Friday is the last day to drop and get a withdrawal. That's the only reason why I'm bringing it up. Okay. I don't think that applies to anybody in this class, so I'm just saying. If you are for some reason questioning that, then come see me and we can talk about it. There's always options. Okay. Immunopathology. So chapter 17 is dealing with disorders of the immune response. So this is whenever the immune response is reacting to something that isn't necessarily harmful to us, but it thinks it is. And so, or it could be underreacting to things that are harmful to us. We should be reacting to. So these are disorders of the immune system. Overreaction or underreaction. Overreactivity, we usually call it hypersensitivity. It could also be autoimmunity, reacting to self when you shouldn't be. Our underreactivities or hyposensitivities, we usually call them immunodeficiencies. We're going to have the two categories of these guys basically broken up between the hypersensitivities and the hyposensitivities. We're going to start with the hyper. There's type 1, 2, 3, and 4. This is why we had to cover chapter 16 before we got into 17, because you can't really understand what each of these are without understanding what antibodies are or what T cells are and how they work and stuff like that. So there's that. And then we'll talk about the hyposensitivities second. Our goal for this major first step in this chapter is to understand what aspect of the immune system generally governs each of these responses. So we're going to start with that first. Hypersensitivities can be triggered by either endogenous or endo or exo, basically, allergens or antigens. So endo stuff would be reacting to self. That's what it means. Exo stuff is anything that's came from outside. It should be self-explanatory at this point. We've used these terms quite a bit, yes. So the four major categories of our hypersensitivities, of our overreaction responses. Type 1, these are our responses that are mediated by IgE, and we typically call them allergies. They lead to either atopic, which are local allergies, or anaphylactic responses, which are going to be systemic allergies. But they're all governed by IgE, and then the IgE interacting with the antigen, which we call an allergen, okay? When the allergen interacts with IgE, it causes mast cells to degranulate. We're going to talk about what that means and how that causes an effect as we get through it, okay? Type 2 responses. Here we have IgM or IgG, our general immune guys, are antibodies that are general response. And these guys are going to be causing antibody to bind to typically red blood cells. And when antibody binds to something, that triggers the complement cascade. Remember, if antibody binds, we can trigger complement cascade through the classical complement pathway. When we trigger that classical complement pathway, it causes complement to create what we call membrane attack complexes, or poking holes in the target cells. In this case, we're talking antibodies binding to red blood cells and then causing complement to poke holes in the red blood cells and causing them to explode. That's a problem, right? We don't want that to be happening. So these are usually blood type related diseases in the type 2, but it's mediated by complement mediated lysis caused by IgG and IgM to blood groups. Okay. We'll talk about it and how it works and all of that as we go through it. Is this the right camera? No, I'm sorry, I didn't even check it. Yes. Okay. I'm a little bit sideways, so I'm just going to read it. So that if I start doing demonstrations, at least I know that I'm showing it to the right camera. Okay, so type 3, also mediated by IgG, but in this case, it's not IgG causing complement. In this case, it's IgG binding to antigen, and then those complexes of IgG and antigen, that basically almost like agglutination. Think of it that way. And those agglutinated complexes get stuck in tight areas in the body. So in our capillaries, in very, very fine capillary places, in our joints and things like that. And then our immune response reacts to those things stuck in those places. This will probably start to track when we start talking about the effects of it and the diseases that are associated with it. Type 4 hypersensitivities are related to T cell, specifically cytotoxic T cells. So this is our CD8 cytotoxic T cell responses. Now, if we reacted to an inside antigen and we first stimulate our T helper response with the outside stuff, make our T helper 1, and then we activate the inside stuff, have our CD8s trying to kill infected self cells, and we start triggering them with TH1 and giving them the go-ahead to kill self cells and whatever like that. The memory CD8 cytotoxic cells that we make will have a few of them set aside. They're not enough, just the memory ones, to basically allow us to protect. We have to activate the memories to multiply back out again. We don't have to go through that whole process of proliferation and differentiation and da-da-da-da-da-da again. That was already done the first time we saw it. But with our CD8s, our memory cells will have a few of them. They still have to multiply back out. It still takes a couple of days. So anything that you have memory against something that is CD8 memory, it takes a couple days to respond with that memory. It's less than the week or two that we had the first time, but it's still a couple days. And you know these reactions because you probably had them. Anybody in here ever have poison ivy, ever? Okay, so you're lucky if you haven't, but if you have, that's a type 4 delayed hypersensitivity. If you go out there and you touch poison ivy, you do not get the rash within minutes. It doesn't happen immediately. It's not like hives or something like that that happens within minutes of exposure. It's something that happens like a day or two later. And that's how poison ivy works. It's a delayed type hypersensitivity. We'll talk about how that works and how that's mediated in a little bit. So it's a common one. Anybody in here allergic to jewelry, like metal? So I'm highly sensitive to metals, but I wear cheapy jewelry. I'll wear cheapy earrings and stuff all the time. These ones are not the cheapy ones. But I'll tell you, I'm allergic to pretty much anything that is not gold, silver, or stainless steel. I will have a reaction to it, but I can wear them for a day. But then maybe a day or two later, I'll get it's crusty, it's red, it's very irritated, it's nasty. It's a type 4 delayed type hypersensitivity. My T cells are attacking my own cells because it thinks that they're infected inside, when it's really just metal that got caught up on the cells. My body reacted to it. So it's not a true allergy mediated by IgE in that case. It is a type 4 mediated. It's a delayed type. All right, so we're going to talk about these different things. starting with type 1. These are the hypersensitivities mediated by IgE and that stuff. We call these allergies, and anything that triggers the allergy is called an allergen. Pretty straightforward there. It's a hypersensitivity mediated by IgE. These are immediate onset. Once you have had a sensitizing reaction, you have seen the allergen, and you've developed making IgE. So remember, when you first see an antigen, you have to activate your T helper cells. The T helper cells become Th2s. Then the Th2s can activate the B cells. The B cells get activated to become plasma cells. Then they make IgM first. And then the IgM has to class switch to IgE. And now you have IgE. And that's how you get the IgE. So that's a long stepwise process that takes like a week or more to get to IgE. That's your sensitizing dose. So the first time that I ever interacted with a cat, for example, I got my sensitizing dose to cats. But then every single time that I see a cat after that, we can just make IgE. And we can also degranulate our mast cells. This is how it'll work. We're going to talk about it, but first we're going to introduce the levels of our allergies. These are our atopic versus anaphylactic. If it is local allergy, like you just get an upper respiratory attack, or just your eyes and your nose are itchy, that sort of stuff, or if it's your skin, or anything like that, that's atopic. Atopic. If it is systemic through your bloodstream and getting causing basically like vasoconstriction and stuff like that in your whole body, that's anaphylaxis. But they're both mediated by IgE. And you can have levels of severity within those. You can be mildly allergic. And there's levels of allergy within each category too. Like I'm going to tell you, I'm allergic to cats. Some cats can put me into near anaphylactic response just from being in a house that they lived in. You can like clean it all you want. But some of those cats, I don't know what it is. Some cats, I will have to leave houses because within an hour, like an hour, because I cannot breathe. It's closing off. But there's other cats, like my sister's cat, that when I'm over around them, I get a little itchy, but I'm otherwise fine. Depends on the allergen, right? It's very specific that way. So there's that sort of stuff too. All right. What we have noticed is that people that are exposed to a lot of antigens in their life, the more antigens you're exposed to, the less likely that you are to have an allergy. That just means that your body has trained more as to what it should react to and what it shouldn't react to. So the cleaner a life that we live, the less antigens you've seen, the less training that your body got early on in age. So we believe this is provable because people that grow up on farms or spent a lot of time outside are less likely to have issues with their immune systems, like allergies or even autoimmunities. But people that spend a lot of time inside, like a lot of the modern cultures today, are more likely to have allergies. Yes.
As far as like humans good when you first send your kid to daycare and they get like really sick for like 6 months.
It's the same thing.
Then
It's
they're
like
fine
you're
for it.
exactly, and then they're like getting trained to being around the pathogens. Yes, and then their body gets memory and things like that, and then they're protected. It's the same kind of a thing. So we think that this is linked pretty highly to that. So what we'll see too is that people that grow up in third world countries where there's very limited hygiene practices almost never have allergies. So allergies, typically type 1 allergies in particular. IgE is usually the antibody that's used for fighting parasites. How many parasitic infections do we have in the US? Almost none. They're very rare here. And so we're talking here protozoa and helminths is what we're talking about with parasites. So we don't have very many of those types of infections here in the US, not regularly. So we don't get a lot of training, our body doesn't. And so it doesn't really know what to do with IgE and the signaling and never got trained properly. So that's the hygiene hypothesis, the idea that we have such a clean society, we're not exposed to enough microbes to properly train our body, so we're more likely to have allergies later on in life. Okay, that's the hygiene hypothesis. There's a question about it. Let's knock it out real quick. The hygiene hypothesis, what does it propose? Righty, so lack of exposure to microbes can lead to allergies, again, because that lack of training as to what we should react to when, where, and how much. So what type of allergens are there? This is pretty straightforward. Things you inhale, things you ingest, things that could be ejected, or things that you contact. So examples of inhalants, pollen and dander. examples of ingestants, food type things like peanuts and stuff like that. Drugs also. Injectants also could be drugs, vaccines. Bee venom or wasp venom would also fall into the injectants. They're natural injectants, right? But they're still injectants. Contactants, things that you would touch with your skin. This could be cosmetics, detergents, and all sorts of stuff like that. All right, so here's how our type 1 allergic response would work. We have our sensitizing dose of our allergen getting into the body. We activated our T helper cell, which activated our B cell. The B cell becomes the plasma cell. The plasma cell makes IgE. That's your sensitizing dose. The IgE doesn't just stop there, though. The IgE gets picked up by mast cells that are in your tissues all throughout your body. And the IgE basically gets decorated on the surface of the mast cell. They can wear it like a receptor. So those mast cells get decorated with different IgEs, different allergens, whatever. They just wear them around. The next time that your allergen comes into the body, up here at number 7, it's not set up the same way as my other computer, so hold on. Up here. So we see the allergen again, it comes in and it binds with the IgE on a mast cell. Plus the allergen, which is an antigen in this regard. And that will lead to degranulation. What is degranulation? This is basically the mast cells sit there with these granules. They're little vesicles that contain cytokines, signaling molecules that are going to be pro-inflammatory, typically, or like vasoconstrictors or vasodilators, depending on what we're talking about, okay? And so they will basically release all of these cytokines to signal to the body, we need inflammation here. What types of cytokines am I talking about? I'm talking about histamine. So it's histamine and bradykinin and serotonin and things like this that are all related to the inflammatory response. There's a whole bunch of them, and I don't need you to memorize them now, but you'll probably learn about them whenever you guys get into nursing school, okay? But we know histamine. Most of us are familiar with that, okay? So that's an example of one of them here. So IgE covered mast cells. We primed the mast cells with IgE. They see the allergen, they degranulate, they send all the signals for inflammation. All right, so here's the idea. Which antibody is associated with allergy in mast cells? Which antibody is this? Hopefully I've said it enough at this point. For type 1, so it's going to be IgE. Good job, guys. All right, so atopic examples of this. Hay fever, we also learn it as allergic rhinitis. So this is another time where I want to introduce a concept to you guys. We're going to hear a lot of itis, and like the rest of the semester, we're going to hear itis a lot. We've had a few incidences talking about something itis or whatever. Itis always means inflammation. So if there's itis, there is inflammation. Sometimes that inflammation is caused by infection, but sometimes not. So even if you have arthritis, so arthritis is inflammation in the joints, right? That's maybe not even a more direct one. When we see rhinitis, we think rhino, we should think of nose, right? And then itis is inflammation. So allergic rhinitis is allergic inflammation in the nose. There. Can you have rhinitis caused by something other than allergies? Of course. So having a cold is an infection that would lead to rhinitis. So it's infectious rhinitis there, right? So there's still rhinitis. Anyways, so the allergen comes in, it causes inflammation in the nasal cavities and such like that. In the case of asthma, we have inflammation in the lower respiratory tract, in the lungs. We'll have degranulation of the mast cells in the lungs as a result of that. So that's still atopic, it's still local. Eczema is another one, we call it atopic dermatitis. So derma being the skin, itis being inflammation, it's associated with allergy and degranulation causing that inflammation basically being expressed in the skin. These are extreme cases of eczema, but you can even have mild eczema being triggered by certain allergens. Most of the time, eczema is not triggered by a contact thing. It's almost always triggered by an ingestant or an injectant or an inhalant. So that's what we'll usually see eczema. Can you have eczema from a contactant? Yes, of course you can, but it's just less common. We see them a lot with inhalants and ingestants. All right, food allergies, things that you ingest can lead to GI symptoms, eczema, hives, rhinitis, asthma, and even anaphylaxis from things that we're eating. So it could be a variety of things, but you can also just have GI symptoms from allergies to things you ingest. What determines which kind of reaction you're going to have? It's your body and how your body receives the signals and what type of allergen it's interacting with and stuff like that. So your body's different than mine. Okay. So again, just depends on what you're allergic to and what your IgE sees and what signals it's receiving at that time. Drug allergies, the most common drugs that you're likely to be allergic to. You could have anywhere from a mild rash or up to anaphylaxis. Typically, if you're allergic to a drug, the first time that we start seeing allergy response, it's usually a rash, but if you keep getting exposed to that drug, then you'll continue up towards anaphylaxis with each increasing incident of being exposed to that drug. So even though you might have had a rash your first time that you had a response to it, your first allergy response, your next one might not be a rash. It might be even anaphylactic at that point. So anyways, most common drugs that you're most likely to be allergic to are going to be penicillin type antibiotics. So any of the cillins. So if you're allergic to one cillin, you're allergic to all of them. I can't ever have any of them. Sulfa drugs, usually again, if you're allergic to one, you're allergic to all of them. Aspirin. So we call these salicylates. Aspirin is acetyl salicylic acid. And if you're allergic to acetyl salicylic acid, you're allergic to any of the salicylic acids and its related drugs. This includes salicylic acid, like you would use in an acne medication. It includes bismuth salicylate, which is what's in Pepto-Bismol. Try to think about doing this because I'm imagining drinking it. But anyways, anything that's based in a salicylate, you would not be able, you'd be allergic to any of them. Opiates are very common for allergies, and then contrast dyes that we use in x-ray is very common for allergies. There are other ones too, but those are the big groups. All right, our injectants, like bee stings, and antibiotics and other drugs that we're injecting, not just ingesting or putting on the skin, right? So here, most of the time when we're causing anaphylaxis, we're causing a systemic. So now we're sending the signals through the bloodstream and having the response in the bloodstream throughout the tissues of the body. This is a huge problem. It causes massive disruption in homeostasis as a result of this, because it's massive inflammation throughout the whole body, and it will lead to vasoconstriction to the point that you will actually lose blood flow to the brain and will die from it. So that's what causes the death associated with anaphylactic shock. So massive, massive loss of blood pressure, hypotension, and vasoconstriction to the extremities, including even to the brain as a response, because your body's trying to shut out the allergen from having a reaction in where it thinks it's coming from. But the problem is that the phone call's coming from inside of the house. It's in the bloodstream, so it can't really shut it off. So that's the issue with that. Yes. Okay. How do we block allergic responses to these types of things? We can use any version of anti-allergy medication, anything that prevents producing the IgE, blocking the IgE from interacting with mast cells, blocking the degranulation of the mast cells, blocking the signals that the mast cells are sending out, and all a variety of basically blocking the inflammatory response. Most of the drugs that we use that would be most effective are things like steroids. Steroids are diffusely, generally, very anti-inflammatory. They're also, if you know better, and you also know steroids are very unhealthy for you. You really shouldn't be taking a steroid unless you absolutely need it, number one. Number two, if you need the steroid for short periods of time, anything beyond a few days, and it becomes dangerous. You really shouldn't be on steroids for longer than 3 days unless absolutely necessary according to your doctor. If you're having chronic eczema that's leading to massive inflammation all over your body, then steroids might be the only thing that can be effective for maintaining it. But that's treating the symptom, not the cause. And so the real goal should be treating what's causing this person's inflammatory reaction, not just stemming the effects of their inflammatory reaction. So that's really the problem with those types of drugs. The other thing with blocking inflammation, we've already talked in this class about how inflammation is one of the steps involved basically in fighting an infection. We need inflammation. It signals for our cells to get there. It signals our cells to come fight. It signals for them to multiply. It does a whole lot of stuff in helping control the infection. So if you block inflammation, you block that generally, not just for your allergen, but for any response to any invader. So what we see is when we take drugs that block inflammation, we have a significant increase in infection as well in patients. That's true of steroids. It's true even for things like Humira. So Humira is an antibody that we have developed that blocks the signaling of one of our inflammatory steps, which is TNF alpha, which is tumor necrosis factor alpha. And Humira, which is adalimumab, whenever we give that to somebody, we are basically blocking that cytokine from signaling for inflammation. It's very effective for blocking that inflammation, but it's also very effective at blocking inflammation, which is needed for signaling for our body to fight off infection. So if you or anybody that you know has had to take something like Remicade or Humira or something like that, then you probably know they've probably had other infections, things like yeast infections and stuff like that. They're way more prone to that stuff. So then it becomes a matter of, would I rather fight my inflammation or risk having these side effects sort of infections and things like that? And so what you'll find is that more often than not, people will decide not to stay on those medications simply because of the risk of the infections associated with them. All right, antihistamines, a little bit more specific here. We're blocking specifically the histamine here. The drugs that block histamine from binding to their receptors and causing its effects. We know some of these, like Benadryl. Most of us are familiar with Benadryl, and that it is an antihistamine. Benadryl, also known as diphenhydramine, okay, that's the drug name, is diphenhydramine, does cross the blood-brain barrier and has side effects, neurological side effects, things like drowsiness, pretty strong drowsiness, but it is very effective for what it is. Again, if you're having an anaphylactic response, we're not going to give you Benadryl. It's not going to act fast enough, and it's not going to do what we need to do at that point. Antihistamines aren't going to stop the cascade of what happens with anaphylaxis. So this is really more for atopic types of responses. If you're allergic to cats or mold or something like that, this can alleviate those symptoms. So Benadryl, diphenhydramine is a good example of that. Cetirizine, which is Zyrtec, excellent choice for that. It does not cross the blood-brain barrier. So it works similar sort of way. Not as strong or as effective as Benadryl, but it is fairly effective. It's probably the most effective of our antihistamines that don't cross the blood-brain barrier. Levocetirizine, which is Allegra. And if you've heard of Claritin, almost no doctor will recommend that you take Claritin. It doesn't actually work. It's never been proven to actually be effective. It's sort of like if you've heard of phenylephrine. So there's pseudoephedrine and there's phenylephrine. Phenylephrine has never been shown to be effective for anybody for causing decongestant relief. Don't take phenylephrine. If you're not building a meth lab, just take the risk to go to the pharmacy counter and get your Sudafed over the counter. That works. Sudafed works. Just take your ID up there and get you the Sudafed. It actually works. Just saying, if you need a decongestant. And you already know the rule about Afrin. Yes, no more than 3 days, only as directed on the bottle. Okay. My dad did too.
My husband does too.
I cannot with it. And you become dependent on it just to breathe. That inflammation becomes chronic. This is the same kind of a thing. It's the exact same thing. If we dampen your immune response too much, your body tries to compensate over that. And then you have excessive inflammation. And when you take the thing away, we don't need it. So don't do it. If you need Afrin for a couple days, it's fine. It happens. We've all needed it once or twice. But don't use it more than it says. It says 3 days. You're only supposed to use it twice a day, 12 hours. That's it. Just follow the bottle, please. Or consult an ENT. If you need any more doses than that, you need an ENT at that point. All right. Epinephrine. Epinephrine is what we administer if you're having anaphylaxis. Okay. So there's some really, and I learned this from one of my students who is a paramedic, and he was teaching me about the difference between like EpiPens versus the epinephrine that they give you in the hospitals. So I learned this from one of my students, which is to say, if you have an EpiPen, then that dosage is either going to be dosed for the average adult or for a child. And that's pretty much it. Your average adult or a child. And it's like within weight ranges. Usually it's like you'll be gifted this EpiPen if you're in this weight range or this one if you're a child. All right. And it must be administered intramuscularly. That's why we always see people giving it in their leg, because that's the biggest muscle in your body. You got the quad, it's right there, it's easily accessible, and it's usually not covered by too much fat. That needle can go right into the muscle and administer epinephrine intramuscularly. That dose is higher, relatively, we'll say per volume of the dose, because it needs to get into the bloodstream and get enough into the bloodstream to have an effect on your blood and your heart and stuff like that. If we give epinephrine via IV, the dose is lower per volume because it's being administered directly to your heart. And so the doses then will be calculated based on your estimated height and body weight and things like that per the patient at that point. Here's what I want to say. Your body metabolizes and uses epinephrine, which is adrenaline. They are the exact same thing. If they are administered medically, it's epinephrine. If it's your body making it, it is adrenaline. And there are drugs that can actually cause your body to produce adrenaline naturally, and it would have a similar effect. So you can either give epinephrine directly or cause the body to produce adrenaline, and they should have a similar effect. All right, having said that, the effect of both adrenaline or epinephrine, same thing, right? It's only about 15 to 20 minutes. So if you are allergic to shellfish, and I'm allergic to shellfish, and somebody in here starts eating shrimp, and usually you'll know it. You'll start feeling the itch in your throat. And if you have allergies to something like this, you might already be looking around being like, who's got shrimp? You might smell it at first. And some people will know it. They'll be sensitive enough that if they even smell shrimp, they'll be like, I got to leave and I got to make sure I know where my EpiPen is. And if they start having those symptoms immediately, they should know that they should pull out their EpiPen and give them the shot before we get to where it's hard to breathe, right? Right. If you ever have somebody that you know has that type of an allergy that could put them into anaphylactic shock to something that they might see regularly, like peanuts or shellfish or something like that, and you know they have an EpiPen. I had a student in one of my classes be like, well, I was told never to administer somebody's EpiPen for them. Absolutely administer their EpiPen for them. If they can't administer it for themselves, absolutely administer it for them. They will die if you don't. I'm being serious. They will die. And then what? They're going to really wish that you'd given them that EpiPen. Rather risk you administering it incorrectly and saving their life than not administer it at all just because somebody told you not to. So absolutely administer it the safe way. Remove the cap, jam it into the leg, and plunge down at the same time.
I'm actually walking through it now too.
Yes.
They talk you through
Yeah,
it.
they'll like have a verbal thing of like what to do. Yes. Some more fancy like that. And then even if you forget, it says it on the pen, even if it's not a verbal one, there is instructions with pictures on the pen on what to, it's very easy. It really is. So if you ever have somebody having that, or they're like clearly having an allergic reaction and they can't breathe and they can't find their own EpiPen, help them. Give it in their leg, in their quad. That's the best place. You're less likely to have fat to impede it. Don't go for the butt. Don't think like, oh, they're having an attack. I need to do it in their heart. This isn't Pulp Fiction, okay? We're not doing that. Give it in the muscle, in a large muscle. You want to do it while they're still able to breathe some. Once we get to that part where their airway has closed off, it is very unlikely that an EpiPen will help them. It just won't be enough of a dose. Let's say that this happens. Somebody has an itchy throat and then, oh no, it's shrimp. Oh no, that's what this is. They pull out their EpiPen and they EpiPen themselves. And they start being able to breathe very quickly. It's almost instantaneous. Very, very quickly. Within seconds, they'll start being able to breathe again. Are they good to go? Are they safe now? Nope. You call 911 immediately. If they had to administer that EpiPen, you need to call 911 because that allergen is still there in the environment. And as soon as that epinephrine wears off, they're going to have the attack again. And it's going to be anaphylactic still, not any less. It's going to be just as strong. So it only buys you time to get emergency help. So I have to always review this in the class. You guys will learn more about this going into medical, care for patients, and you'll learn about that stuff. But I feel like this is useful information for anybody at any time. Anytime that anybody's having an anaphylactic reaction to anything. Huh? Oh no.
I'm not clear though. I don't know if it's a following process or specific ones. I just keep trying.
Yeah. So I don't have anaphylactic responses to anything. So I have borderline anaphylactic response to some cats. Like I said, I mean, this is genuine. Like, I don't know, some cats really do. It'll be like within minutes of being in a house of somebody that has that cat. I'm like, I can't, we're done. We're out. We have to go to I've had to go to hospitals for it before. Yes.
This could be it, maybe not, but like some cats, particularly breeds, have terrible dander, not even fur.
Yeah.
And you can't tell unless you're allergic.
Yeah.
And then like a lot of those long-haired cats you see are actually hypoallergenic because they don't have dander. They don't have
Yes.
so much fur.
So what I learned about the cat allergy thing is it actually is related to an enzyme in their saliva. And so because cats groom themselves, and so it isn't indirectly related to the dander because they'll lick themselves and then it gets carried on the dander or the hair. And then that gets distributed through the house that way typically, but it's there in their saliva. And so some cats just don't make as much of that enzyme or don't make the enzyme altogether. And of course, if they're not having as much dander or hair, there's not as much vector available for them to transmit it around. So that's what I've learned. And like you can become desensitized to some things as well. So again, if I had a cat that I was okay around and I continue to be around it, my body gets used to that cat. I even had in graduate school, my best friends got a cat. And because I was over at their house all the time, eventually I could sleep in the same bed with that cat and not have any reaction to it. I got used to that cat, but not all cats, just that one cat. All right. And I used to volunteer with the Humane Society and they always wanted me to clean the cat rooms. And I would do it. I would just load up on Benadryl before I would go and I would wear masks and like all this stuff. I would do it, but I would do it. I like cats generally. I like the idea of cats. Okay. Well, I just don't do well, but it's the same thing. We're like, I will almost always go to, like, I went to Dr. Tim's house for a party one time. He has cats and he has this very, very friendly cat that always wants to be petted. And I knew it. I was like, I'm going to have to pet this cat. And I just asked Tim, I was just like, Tim, you got Benadryl because we're going to have to pet your cat. And I'm going to need help. So yeah, so it's like that, like you said, with your wine, it's like, I'm not willing to give it up. I'll pet cats and I'll just have to take Benadryl. And like, if it gets that bad, then I'll remove myself from the cat situation, but yeah, it's not anaphylactic usually. But anyways, epinephrine, it's short-lived. That's my point there. Okay, so here's the question. This is kind of, there's two answers that are correct to this. What is the preferred way to treat anaphylaxis? What do we want to either administer or initiate? Two of these are correct because they're the same. I'm allergic to whey protein, like whey. And yes, I'm not giving up cheese. So I just eat it in moderation. And I get inflammation in my gut sometimes from, I've had colonoscopies, I'll be like, man, you got all this inflammation. I'm like, it's the cheese. What do you want me to say? Like, that's just how this is going to go. But yes, so epinephrine and adrenaline, diphenhydramine, that is going to be your Benadryl, and lorazepam. This is the benzodiazepine that we're not going to be giving for allergies typically. You might need it later on. If you've had one of these attacks, we might need to calm you down to calm down your anxiety with that, but hopefully not. All right, so desensitizing. The idea with desensitizing, we're not causing your body to produce less IgE. You still have the IgE, you still have the IgE primed mast cells. But instead, what I'm doing is by going and seeing that cat regularly, what I told my body is you need to make IgG against this cat's allergen. This cat dander. My body's seeing it regularly and in smaller doses. And now my body's building up IgG. Now, this is the thing. Remember, when you're a B cell, when you first see getting antigens, what I'm trying to say. When you first see an antigen on your receptor, you have IgD. We see the thing, we take the IgD in, we present the antigen on MHC2, we get activated by our T helper 2 cell. Now we're activated, the first antibody that we make is IgM. And based on the signals we're getting from the body, we will class switch from IgM to one of the other types. In an allergy response, you've got signals to switch to IgE. But if we keep seeing something in the right context, we might switch over to IgG too. And if you get signals to make IgG, you will make a lot more. We're talking 8. Usually, I want to say 8, that's not quite right. I want to say 800% is what I'm trying to say, like 8 times as much of the IgG. So you're inundating the body with IgG. And if you have enough IgG, which is more effective, we're gonna have more of it, it's gonna be in the bloodstream, it's gonna be all around the place, then the IgG will bind with the allergen so that IgE can't. So the IgE basically eats up the allergen so that it doesn't interact with IgE on the mast cells. IgG will do that. with the idea of desensitization. So we can actually induce that intentionally. So if you have really bad hay fever, you can go to an allergist and they'll give you doses of whatever specific thing you're allergic to, ragweed or whatever, in doses set up in a way to try to initiate IgG response so that you don't have the allergy anymore. We can do this and we can target it that way.
Is it a permanent fix or is it like you have to keep?
It should be permanent. Once we have triggered the IgG, and especially if you're seeing it regularly, like your own body will initiate that after that. Once we get the IgG made, your body will maintain it after that, especially if you're seeing it regularly. So common allergens like that. All right, so we're moving on to type 2. Type 2 are our blood type reactions, but first we have to understand what blood types are and what they represent. The first type of blood type antigens that we're going to talk about, these are all called alloantigens. So again, these are not markers that tell you that this is something bad. It's just our body, my body was never trained to see. So I have type A blood. My body never saw B as normal. It didn't learn that that was something we shouldn't react to. So my body will make antibodies to B. It looks foreign to me. So, for example, so we'll talk about these. There are 4 different blood groups, A, B, AB, and O. There, I want to get to the next picture. There it is. This is better. This shows it better. Nope. Here we are. Nope, still. And I'll switch to blue. Okay. This is type O. So we notice something about O. It's the basis for all of the other ones. Typically, there is a blood type called a null type, which is, this isn't on there. It's very, very, very rare. We've only had something like maybe between 10 and 100, I can't remember, but 10 and 100 occurrences in all of history that we have documented. So a null blood type is extremely rare. But these are our typical 4. Okay, most people will fall into this 4. I mean, most by like 99.99% of the population fall into these 4. All right, so the base for all of them is O. That means you see O as friendly. I see O as friendly. I don't even care what your blood type is. You see O as friendly. Okay. Now, if you are an A, if you carry an A gene, you must express A on your surface. If you carry a B gene, you must express B on your surface. So that means that they're what we call co-dominant. A and B are co-dominant. If you have one, you express it. So you can have both. You can have A gene and a B gene, and you'll express both. Okay? So I want to show you the genetics of this. So we're going to do Punnett squares. Are we ready? I'm going to give you a story. It's based on my life, and I felt like this taught me a lot about my genetics. All right? I am an A positive. My dad is a B positive. My sister is an AB positive. So what do you think my mom has? Probably A. She could be AB. Do you think she could be AB? I don't know. I don't know. She doesn't know. I don't know. Okay, that's just my answer. Okay. But she's an A something. She has an A gene. She must. And she has something else. I don't know what carried on her other thing. I don't know if she's A or AB. Something else. This X is either an a B, or an O. I don't know what it is. It doesn't matter. Okay. With my mom. My dad is a B. Is he a B O or a B B? I don't, well, I'll tell you how I do know. I do know he must be a B O. He must be. And this is why. I'm going to show you what the BB looks like first. If he was a BB, all of the kids, you carry across this way and down this way, okay? So all the kids would be either A, B, B, X, B and A, which is AB, or B and X. So all of the kids would carry B. All 100% of them would have a B if he was a BB. but he ain't. Because A and whatever, and B and O, we're tracking, would be A, B if we carry down and across. B something, who cares? A and O, and whatever and O. This means 25% of the kids would be AB, 25% would be AO, 25 would be whatever this is, and 25 would be whatever this is. We're tracking? I'm an A, and my sister is an AB, and my dad is a B. He donates regularly. Okay. So we know our blood types, me and my sister and my dad. So therefore, I know my dad's a BO. He has to be. That's his genetics. But his actual blood type is B. If you have a B, you express it. Makes sense? Are we following? That's the genetics of it. So I know that I must be an AO. I must be. I can't be an AA because he didn't express A. So I know I'm an AO. This is relevant, I promise, because we're going to go through one more example. Okay. If I'm an AO, my husband, we don't have kids, but let's pretend for a minute, okay? My husband is an O positive. So what does his genetics look like? O and O. He must be, because if he had an A, he'd be an A. Or if he had a B, he'd be a B. So we know he's an OO. He has a gene that's O from mom and a gene from O that's dad. If we have kids, it would be AO, AO, OO, and OO. 50% chance of A, 50% chance of O. We're tracking? Makes sense. So that's how Punnett squares work. Now, unfortunately, genetics is not this simple. For ABO groups, it is. But there are other genes that are regulated by other things besides just getting the gene from mom and dad. So Punnett squares are pretty easy for stuff like this, but they don't apply to every single genetics ever. If you ever take a genetics class, and I hope you do because they're extremely interesting, that you'll learn more about how genetics is regulated and co-regulated by other genes and things like that, and what's expressed and what isn't, and dominance and recessive and combinations of genes and all sorts of stuff. Okay, it's how you get a chocolate lab. A chocolate lab means you have a gene for a black lab and a gene for a yellow lab, and that leads to chocolate. So it's a combination of both. And so they can actually make babies that can be yellow or black or chocolate. Depends. So lovely genetics. Anyways, any questions about this stuff? So this is our ABO blood group. This is the genetics of it, okay? If I am an A, O is good, A is good, B is foreign. We can't do Bs. If I'm a B, O is good, B is good, A is foreign. Can't do it. If I am an AB, O is fine, B is fine, A is fine, AB is fine, right? If you are an O, you're an O, A looks foreign, B looks foreign, O looks fine, AB foreign. We're tracking that? Okay, so this means that ABs can receive any blood type. If you're an AB, congratulations. My sister is an AB positive. We'll get to the positive and the negative in a moment, okay? So she's the universal recipient. Yes. Not yet. We haven't gotten that. Yes, yes, yes. So this is just the A, B, and O group. So this thing here, he's asking if this is the RH factor. No, this is the O group. The O antigen, we'll call it, okay? Which is always the base. Yeah, and if you're no, you just don't have it. Right, so we haven't gotten to that yet. Yes, yes, yes. So this is just about the ABO group. If we're talking about the RH antigen, also known as the D antigen, it's the same thing. Think of that as being another molecule that's on the end over here, the D antigen. If you have the D antigen, you are positive. If you don't have it, you're negative. So you can imagine if you're negative, that's like the base. But if you're positive, you have this extra antigen. So negatives see positives as foreign. period. Positives can get positives or negatives. Now we could make our chart even bigger if we wanted to. Let's erase all of our genetics over here. Should just clear the whole board, but that's fine. If you are A, B positive, you can receive A, B, O, or AB, positive or negative. All blood types. If you are, let's say, A negative, you can receive A and O negatives. You can have no positives and no B of any kind. We're following that? I know where you're going with this. If you're O negative. If you're O negative, what can you receive? O negative. No positives, no A, and no Bs. This is the issue, right? Because anybody can get, you see the trend here. We got an O negative here. We got an O negative. Anybody can get O negative. O negative is the universal donor. But O negatives can only receive O negative. Now let's imagine that there is a mass trauma incident like 9/11. We've got hundreds of people that might need blood transfusions. A type and cross in a hospital can take anywhere from 30 minutes to a couple hours, depending. And if we have a mass trauma incident, I want to tell you, at Baptist, right now, if you needed to go to Baptist and have a blood transfusion, there are 2 people ready to do type and crosses. 2 people that can test you for your blood type. If we have a mass casualty event, like the Murrah bombing or something like this, we have tons of people being rushed to hospitals. There are 2 people at that hospital that can do type and crosses. Now, there are people trained that can help out with that. The stations are set up for 2 people. So there's still going to be a wait. So now you're not waiting 30 minutes to an hour. You could be waiting hours just for a type and cross. So if you're bleeding out and we need to give you blood right away, what blood are we going to give you while we wait on your type and cross? Oh, negative. Oh, negative. Now imagine that you have had 200-300 people come into Baptist that have needed transfusion with O negative. And now you get number 301. And that person's O negative. And that is their blood type. We can't switch them over. If I come in, you're going to pump me with O neg until you figure out I'm A pos. And now you can give me A pos or O pos or whatever you needed to. But if you're O neg, all you can get is O neg. And if we already used all of it. So then what do? We call nearby hospitals and they life flight that over to the hospital. And how much time might that waste you? So this is a huge issue. And so hospitals do keep stocked heavy on O neg, and it does go bad. It only lasts for a little while, lasts for about a month on the shelf. And so this is an issue that whenever OBI is pleading for O negatives to donate, it's not a joke. It's we really need it. And there are, when OBI goes into a plea for blood, so sometimes they're constantly calling you for blood, okay? No matter what your blood type. But if they're in a plea, it means that some blood product is low enough we're having to buy it from out of state. That's a problem. And so they've been on a plea for platelets recently. And that means we're not keeping platelets on the shelf. So I want to be clear about platelets. We know platelets are important in clotting and things like that, primarily in clotting, repairing injuries and stuff like that. You usually have issues with your platelets if you are a little baby and you can't make your own platelets, or if you have cancer. And so when we start running low on platelets live on the shelf for 24 hours. Once somebody donates platelets, it has to be used within 24 hours. And so we haven't been getting enough platelet donors. And so that's the issue with that. So we've been having to buy from out of state stuff. So that's an issue there. But anyways, O-negs, we always need an O-neg. If you know an O-neg that is healthy enough to donate, please encourage them to donate blood. It is life-saving. I can't emphasize it enough. It's life-saving. So I encourage it. Yes. All right, so also something to be aware of. In the United States, the most common blood type, look here. The most common blood type is O, but not O negative. O positive. In fact, in the world, look at this. In the world, O positive is by far the most common blood type. So if it takes two O's to get O's, you need two O genes to be an O. But you can have even just one A and be an A, or even just one B and be a B, or get both and be an AB. Why is O so common? Even comparatively, like if we take almost as common as all these combined, almost. This is an evolutionary thing. Okay, I'm going to explain this. People don't like this, but it's the facts, okay? If you have O blood, you're less likely to get malaria. So where's the cradle of man? In a place where malaria is endemic, right? So all of mankind, I don't care how you think mankind got here. I'm not arguing that, but all mankind seems to have originated from sub-Saharan Africa areas or the Middle East areas where malaria is endemic. So all mankind likely originally came from that area. And so having O as your blood type probably kept you from getting malaria. And so those genes, people that had O, survived enough to have kids and likely spread on those genes. And that's just existed ever since then. Mosquitoes also prefer O blood. So we had to have that because mosquitoes already preferred your blood. So it just favored people that were less likely to, get malaria and stuff like that. So anyways, it's a big thing. It's big if you're interested in that sort of stuff. I feel like it's really interesting if you're interested in that sort of stuff, the history of man and how O's exist and why. Anyways, interesting stuff. Okay, moving on to the Rh factor and the D antigen. If you have it, you have it. If you don't have it, you don't. So think of that one as being like you are A, B, or O, and you may or may not have this Rh, the D antigen. The issue is that my attack against the Rh group is actually stronger than it is against the ABO group. If I transfuse somebody who is A, like me, if you give me my dad's blood, he's B, then my body will attack it with antibodies. That will cause complement to poke holes in his cells, release all the contents of his cells, and then my body is going to be like, what the heck? Why are we busting open red blood cells everywhere? And I'll go into shock and die. The most common results of getting the wrong blood type this way is going to be shock and death. It's most common. That bad. But now he's B positive. And that's not me attacking the positive, because I would see that as friendly. That's just me against the B. But if you give somebody who's a negative, a positive blood type, it's even worse. This is so severe, in fact, that if you are a mother, let's say you're a mama, really? Let's say you're a mama, and you are an O negative mama. Actually, let me draw this differently. Here's her head. Here's her baby, belly. And inside of her belly, we have an A negative. Okay. She will make antibodies that are anti-A. She will. And those antibodies can attack the baby. Now, while the baby's growing in the womb, we have the placental barrier. The antibodies won't cross it. The baby's protected. But once she goes into labor, the barrier is no longer maintained, and the antibodies can attack the baby. This more commonly in ABO situations, this will cause some anemia in the baby. This often leads to bilirubin being released from the liver, damage from the red blood cells, leading to effects in the spleen and the liver, causing release of bilirubin into the skin. You get the yellow babies. This is one of the most common causes of a billy baby, is the ABO rejection. It's totally survivable, generally speaking. Treatable, baby gets out, the antibodies go away, they put them under a billy light, baby's fine. Helps the baby reabsorb the bilirubin by breaking it down with the UV lights. If you don't know anything about it, you will. Okay, so there's that. Now let's imagine that the mama is pregnant. This is my husband's situation. So he is O positive, and his mama was O negative. The mama will make anti-RH antibodies. Antibodies against that positive. This is a stronger effect. So here, the mama makes anti-RH antibodies that will attack the baby. Once the mama goes into labor, it attacks the baby, leads to hemolysis of the baby's blood cells, and usually leads to death of the baby. You carry a perfectly healthy baby all the way to term and then get to watch it die. This still happens today. Why might it happen today? If we didn't get that mama treated with RhoGAM early enough. So if you go into preterm labor, this might happen because we didn't get you RhoGAM in time. If you go to a new doctor and you didn't know that you were negative having a positive baby, so they didn't administer you with this in time, and now you're in labor or you're traveling somewhere, whatever. There are all sorts of reasons why we might not have gotten you treated with RhoGAM in time before you had birth to your baby. And your antibodies attack the baby, and now the baby dies. If it's your first baby, this won't be an issue because you have to have a sensitizing event. The first baby is the sensitizing event. Now, if it is your first baby, will doctors still administer RhoGAM? Because they don't know that this is your first baby, and you might not know. You might have had a miscarriage and not known. It happens a lot more than people realize. And so that's why we usually, if you are Rh negative, and we think there's any risk of the baby being positive, if we don't know the father's blood type or something like that, then we will give RhoGAM just in cases. Okay? Safer to give the RhoGAM than to not give it. All right, any questions about this? So the disease that this would cause, we call it hemolytic disease of the newborn. It can be ABO related, but it's most important with the Rh group. And that's where RhoGAM comes into play, is with the Rh group. So RhoGAM is a drug. Oh, okay, there's a question. We're gonna skip it. RhoGAM, where is it? There it is. Okay. RhoGAM is a drug that blocks the antibodies against Rh. It's a drug that blocks the Rh antibodies. And they're anti-Rh immunoglobulins that block. They're antibodies that block the antibodies. That's what I'm trying to say. They're antibodies that block the antibodies from doing their attack. Okay, that's what RhoGAM is. All right, any questions about that? It's hemolytic disease of the newborn is what that is.
That's all of the ones that.
Mm-hmm. Yes. If she's positive, negatives look fine. Mm-hmm. Make sense? It's a good question. So there's a question on it. It's just, what disease is that called? So if you have a previously sensitized Rh negative mama who has a second baby that's Rh positive, what disease could that cause? I can actually answer this one. I'll leave it up. So again, these are all IgG and IgM related, leading to complement lysis of blood cells. So that's type 2 hypersensitivities. That's where we're still at. Next is the type 3. Type 3 is mediated by immune complexes. Here, we have antibody complexing up with antigen. These immune complexes get stuck in like capillaries and stuff like that. Neutrophils come in and try to start to get rid of and eat up all that stuff and start releasing inflammatory cytokines. Inflammation causes damage to the nearby tissues. The nearby tissues in these tiny little areas, in small blood vessels, in heart and lungs, where we have a lot of small blood vessels where gas exchange occurs, in the joints, which are tight spaces, in skin, where we have lots of small capillaries feeding out into the extremities, and then in the kidneys. So if you've learned anything, anybody in here taken anatomy or physio? So you might have learned a little bit about the kidneys and a structure in the kidneys called the glomerulus. Yes. Glomerulus. Glomerulus. The glomerulus, okay? And it's part of the kidney. And it's where we have the exchange from the bloodstream, basically taking out toxins and stuff like that and moving it into the urine through the urinary system. It's where that exchange happens. It's in the glomerulus, this is very delicate structure where we have this very unique, it's just wavy structure. They draw it as like a wavy structure, but it's really a lot more complicated than that. And this is a site where we have blood toxin gas exchange, as well as like electrolyte exchange and water exchange and all this very delicate structure within the kidney called the glomerulus. The kidney itself, nephrology is the study of the kidney. So nephro means kidney, glomerulus is that site in the kidney where that exchange happens. So glomerulonephritis is going to be inflammation of that part of the kidney. Okay, so this is caused by antibody antigen complexes getting stuck in that structure in the kidney as a result of having had strep. So mixtures of strep bacteria and antibody being filtered out through the kidney get stuck in the glomerulus, and we have inflammation there happening because of this type 3. So this is called acute post-streptococcal glomerulonephritis. Okay. Yes, and I'm not going to ask you to write that one on the test. That's not going to be a short answer. It might be a question asking about what type of response it is, but I won't make you write out acute post-streptococcal glomerulonephritis, okay? Okay. So this is a type 3 reaction, right? Immune complexes from having had strep get caught in the glomerulus, leading to inflammation of the kidney. It is acute. What does acute mean? It means it can cause severe disease for a short period of time, but you should be able to get over it and clear it. So not everybody gets this, obviously, when you have strep. Some people do, and it can cause kidney damage if this happens. And it can be pretty severe if it is severe enough and prolonged enough. There are other type 3 reactions that we will talk about later. I'm going to skip this. Type 3. Cool. We'll talk about them later when we get into the autoimmunities. Next, we're moving on to the type 4 hypersensitivities. These are all mediated by cytotoxic T cells. Okay, so again, cytotoxic T cell, we have memory of it. When we reactivate it, it takes a couple days for them to multiply back up, and then you'll see the inflammation associated with it from killing self cells. What's an example of this? Delayed type hypersensitivity, the PPD skin test for tuberculosis. Tuberculosis is a bacteria that gets inside of your cells. So we usually have a CD8 response to it. If you've had tuberculosis and I inject a little bit of its protein under your skin, your CD8 memory cells will multiply up after a couple days and cause a welt on your skin. That's what that test is. You guys are going into nursing school and you had to get it done. If you haven't done it yet, you will have to get it done if you're going into a hospital. Again, not for your safety, for your patient's safety. They want to be sure you're not carrying tuberculosis. If it does inflame up, it means you have a T cell response against tuberculosis. You've either seen it by having had it, or you have it now, or you've had an immunization against it, either from travel or having lived in a country where tuberculosis is endemic and common. We don't give that normally. All right, another example of this is contact dermatitis. This is different than atopic dermatitis. Atopic dermatitis, which we see with eczema, is mediated by IgE. If it's mediated by CD8 cells, then it's contact dermatitis. This is what we see with poison ivy, with poison oak, with the jewelry like I get. With a couple days later, I'll have a rash from cheap, not these ones, but other earrings that I wore. I wore some a couple days ago and I'm waiting for that. Okay, it's going to happen either today or tomorrow later. And it'll be itchy and oozy and nasty, just like a poison ivy rash would, because the CD8 cells are actually destroying self cells in that response. It's mediated by CD8s, as well as macrophages get involved in that mess too. There's some pictures of it. Here we have the activation of Th1s, and the Th1s stimulate our CD8s, and they come in and attack self cells, and we get the buildup of the fluid, the blistering, the damage of the cells themselves, leading to the characteristic aspect of contact dermatitis that we see with poison ivy and other things. This is actually the type of immune response that mediates graft rejection as well. This is because all nucleated cells in everybody's bodies, okay, all nucleated cells have MHC1 on them. You can call out and say, help, help, I found this inside. Any of your nucleated cells can call out for that help. Problem is, my MHC looks different than yours. So my body sees your MHC and says that is MHC, but it looks weird. It must be MHC calling out for help. So my body sees your MHC and it kills your cells because it thinks it's cells calling out for help. That's why we have to do so much genetic testing when we do organ grafts. A ton of genetic testing. So we want to be sure that your MHC looks as much like mine as it possibly can. So we do that by looking at the genetics of the people. And it's always MHC1. We call it the HLA markers. And there are certain markers that we do testing on for people. and certain parts of those genes that are more indicative that the organs will match than other ones will. That's what I used to do at Baptist, is I used to do that test. And it was so stressful. I'm not doing that ever again. So if the body attacks the graft, that's the host versus the graft. So if I'm attacking the kidney because it looks foreign to me, my T cells attack the kidney, that's the host versus the graft. If the graft attacks the host, so normally your kidney cells can't attack. Not really how it works. But what can attack is if I get your bone marrow. Remember, all of your T and B cells come from your bone marrow. So if I get a bone marrow transplant and your bone marrow is put into my body, and now I get T cells from your bone marrow, and those T cells see me as foreign, that's the graft attacking the host. Okay? There's a lot less danger with the bone marrow graft because of the training that those new T cells are going to have to go through. We can actually train it somewhat with anti-self and stuff like that at that point. So there's less matching that has to happen with bone marrow, but it still has to have some kind of match, basic match, okay? But that's the graft versus the host. Only get graft versus host in bone marrow transplants. Every other transplant, there's risk of host versus graft. What types of grafts can you get? Autografts, isografts, allografts, and xenografts. An autograft is a graft from your own body. You get a burn on your arm and we replace it from the skin on your leg. That's an autograft. Isografts, these are from identical twins. Is there ever any risk with an identical twin of rejection? I hate to break it to you, but yes, there is. There is a little bit. It's very minimal, but there is still some risk associated with it. I would go into why, but it gets into a lot of genetics that we don't need to be talking about. And it also has a lot to do with training of the body. Remember, when you're growing up, the microbes that you had as part of your body, the things that your body was trained to identify as self and non-self, might differ if you were raised in different parts of the United States by different people. Some identical twins were. So that might make a difference. So isograft is usually the next safest. It's almost identical. It's as close as you can get. Allografts is any graft from anybody that is not an identical twin or self. So my sister, allograft. My cousin, allograft. I get a graft from Jessica, allograft. Okay. Xenografts are from non-human animals. So this is like heart valves from pigs or cows, for example. We can use heart valves, even vessels and corneas and things like that from other animals. Right. Type 4 hypersensitivities like contact dermatitis and graft rejection involve which aspect of the immune response? Type 4. Good, that's T cell mediated. All right, so this gets us into autoimmunity. So anytime we're having a type 1, it's not usually type 1, but type 2, 3, or 4 reaction against self, then this is going to be autoimmunity. So it could be any of those. It could be systemic or it could be organ specific. There's some examples. You might be like, oh, when is it organ specific? I'm glad you asked. Type 1 diabetes. Type 1 diabetes. Type 1 diabetes, just type 1 of diabetes, not the type 1 hypersensitivity, okay? Because it's a type 4 hypersensitivity. Okay, so type 1 diabetes is a type 4 hypersensitivity, meaning T cells attack pancreatic cells, killing them. And so we actually have reasons for why we think this happens, but we're not going to get into the details too much, okay? But there are reasons for it. So this lists several common types of autoimmune diseases. Of course, there are multiple that aren't listed on here, but these ones are mediated by these things. In lupus, we have a type 3 hypersensitivity. In our tiny little spots in our body, we're having inflammation because of these buildup of antigen antibody complexes. We see that as the butterfly rash on the face of somebody with lupus. So the capillaries in the face are becoming inflamed as a result of that. This happens throughout the body, though. It's systemic. In rheumatoid arthritis, we see the buildup of those antibody antigen complexes in the joints, causing inflammation of the joints, but there's also type 2 and type 4 inflammation that can happen in other areas of the body as well, leading to damage. There's all sorts of different ones. If you're interested, here they are. how do we trigger this? If we're supposed to be eliminating anti-self cells during our training process in our younger ages in our development, then how does this happen? One of the major causes is molecular mimicry. This means that a pathogen looks like you. There's enough about the pathogen to trigger the response, but then after we trigger the response against the pathogen, we also trigger it against you because it looks enough like you. And then your body just keeps that reaction going after that. This is actually probably, we think, more common than you might believe. So we actually think type 1 diabetes and multiple sclerosis might be triggered from viral infections. The interesting stuff. All right. We also think that the training from your gut biome can help train your body as to proper self and non-self. So if you don't have a healthy gut biome, you're actually more likely to have autoimmune diseases. So a lot of research going into the effect of the gut biome and the effects on your overall health right now. That's one of the hottest topics right now. So it's pretty interesting stuff as well. So follow that. That's definitely worth following. So now we're going to get into our immunodeficiencies. You're either primary immunodeficiency or secondary. If it's primary, you had the disorder from birth. It is congenital. It is genetic. You had it from conception. Okay. Secondary immunodeficiencies are acquired after birth. Oh, no, I don't want to do this yet. Okay, so I don't want to get too delayed because it's already 6:12, so I want to get cranking on. Okay, so primary immunodeficiencies. If we have a deficiency in our stem cell that leads to our B and T cells, then you can't make B cells or T cells that work. This is usually SCID. So we call this SCID, S-C-I-D, or severe combined immunodeficiency. SCID, severe combined immunodeficiency. And usually this is, again, a defect in the stem cell precursor. Depending on what aspect of the stem cell precursor is affected, you might have more or less severe SCID. The worst type of SCID you can have is X-linked SCID. We learn about men, and I mean genetic men and women. I'm not having any arguments here about identification. You can identify however you want. I have no problem with it. But if you have a genetic XX versus a genetic XY, the genetic XX female genetic, right? Genetic XY is male genetic. Now, there are some genes on the X chromosome that are linked with your stem cell here. Very important genes. Women genetic women get 2 copies of those genes. So if one of them is messed up, doesn't work right, you have another one as backup. Men would only get 1 copy. If it is messed up, that's the only copy you got. It's messed up. So this is what's associated with X-linked SCID. This is why it's boy in the bubble, not kid in the bubble. It's also why it's not man in the bubble, because they don't live to adult age. They always die. What are they dying from? Diseases. Or they'll get sick and die from just the bacteria in your drinking bottle of water. They can't, no bacteria in the environment at all. They have no defenses whatsoever. That's X-linked SCID, boy in the bubble disease. It's not girl in the bubble, because in order to get girl in the bubble, you need 2 X's that would be bad. How would you get 2 X's that are bad? A bad one had to come from the man. So if the bad one had to come from the man and the man had a bad one, he had boy in the bubble disease. You following that? And they don't ever live to that age. They don't ever reproduce. So we don't see this in women. We only see it in genetic males. Okay. So it's a rough one. There are other types of SCID that are not X-linked, that are less severe, that we can treat with various types of immunotherapies and things like that. We can give them immunoglobulin from donors and things like that to at least give them some protection to live in society. The less severe ones are the ones you'd rather have. And there's other types of immunodeficiencies that you can have that are associated with other types of mutations in the body, like DeGeorge syndrome and ADA deficiency. Both of these are leading to basically the effectiveness of T cells. Now, remember that you need T cells to activate your B cells. Remember, you need T helper cells that activate your B cells. So if you have a T cell deficiency, your B cells aren't gonna work that well either. It's rough to have a T cell deficiency. Now, if all you have is a B cell deficiency, which is this bottom down here, then your T cells should work fine. You'd rather have a B cell deficiency. You might have a gamma globulinemia, which means you don't make gamma globulins, immunoglobulins, antibodies at all. Or you might have hypogammaglobulinemia, which means you have a deficiency in some of your antibodies. Most of these are treatable. We can give you gamma globulin infusions and give you antibodies from other people, plasma donors typically. So we can actually take those antibodies from other people and give them and provide some protection. So you would rather, if you had to pick one, a B cell deficiency. And if you had to pick one between T cell or SCID, you'd pick a T cell deficiency. You would never want to pick SCID. It is survivable, but not boy in the bubble disease, but other SCIDs can be survivable. All right, so this just goes through those. I'm just going to click through them. Secondary immunodeficiencies. These are ones that are acquired after you're born. So you either get these from infections that infect the immune system and affect your immune system. So HIV is the most obvious one. HIV infects your T cells, your T cell count goes down. It's basically defined by your T cell count. If your T cell count is low enough, then you will get opportunistic infections. We also have metabolic disease that can cause immunodeficiencies. We have chemotherapy treatment. If you have cancer that's not affecting your body or your immune system, like let's say you have breast cancer and you're getting chemotherapy for that, that can affect your immune cells too as a side effect. Even radiation, and radiation might be radiation for cancer, but it's not all I'm talking about. Even using X-rays and having exposure to X-rays can deplete your B and T cells. And then being exposed to things like radiation from an atomic bomb or something like that could also deplete your B and T cells. It can lead to permanent or temporary immunodeficiencies. AIDS is our best example of an acquired immunodeficiency from an infection, easily. It's determined by your T cell count. We're clicking through it. Cancers, often leukemia and plasma cell tumors. Again, this is dysregulation of our B or our T cells that can lead to our immune response basically not reacting the way that they should. Okay, that is it for chapter 17. Cool. Okay, I'm trying to leave this. Here we go. Let's see. I'm about to get upset. So we'll do chapter 18 now. This should be a short one. If you were paying attention when you made your concept maps, right, then you will notice that there is a lot in chapter 18 that we've already taught. This is more or less just categorizing what we've already taught, okay? We'll go over the major categories of this. I'll let you guys sign in. And while you're signing in, I'm going to start listing our major categories for this. Our major categories, so that we have reference for what we're about to just mostly click through, okay, are there's kind of four categories. First one are our phenotypic tests. These are biochemical based, selective and differential media, stains like Gram stains, acid fast stains, could be related to brain, could be related to phage typing. We'll talk about what it is, no worries. Could be related to antibiotic susceptibility, Kirby-Bauer. All of these would be phenotypic type tests. Because, now let me clear about this. What makes them phenotypic is the fact that they are not relying on antibody or antigen, and they're not relying on genetics, which are our next categories. So second category, I'm gonna give a little space in case I forgot something. Immunologic. These all rely on antibody, antigen, or something to deal with antigen reaction. Immunologic tests include anything dealing with serotyping or serology. Immunofluorescence. Rapid testing, like talk about immunochromatography. So this was like your home COVID tests. Okay. ELISA. Antibody titers. Tuberculin PPD tests. And Western blot. Some of these we will talk about in a little bit of greater detail. But all of these immunologic tests are either direct or indirect. Remember that from the ELISA thing? If you're direct, you're testing for the antigen. If you're indirect, you're testing for the antibody with the antigen, right? Doesn't matter if you're ELISA or if you're immunofluorescence, if we're testing for, antibody or antigen. Okay, so that's the immunologic test. The third group is the genotypic. Genotypic tests include PCR and other nucleic acid amplification tests. You will see this a lot in your case studies. If your case study says they used NAAT, that means they used PCR or something like it. PCR is a nucleic acid amplification test. Okay. Another one, nucleic acid hybridization. I'm gonna put NA hybridization. We have subsets of this. The first subset is going to be FISH. This is fluorescent in situ hybridization. The second subset of this, microarray. You could also use genome sequencing. I don't think there's anything else that I'm missing with the genome type. Our fourth subset, let me put it over here, is the other category. For the other, there's the imaging tests. I could do subsets of that, but that would be like CT scans, X-rays, stuff like that, MRIs, that's imaging. The other one is the MALDI-TOF, mass spec. I should do that. Mass spec. Mass spectrometry. I'm going to just write mass spec. The subset of this that we need to know is MALDI, MALDI-TOF, time of flight. So here's what we're going to talk about briefly in our last 10 minutes. Okay. Phage typing, because you should know the other tests. So again, briefly just to remind you that you do know these. If we're performing a test to see if your organism ferments glucose, biochemical test. You understand why it's not genotypic or immunologic. If it grows on MacConkey agar and it turns turns pink on your MacConkey agar, then it used lactose. That's selective and differential media in the phenotypic test. Okay. All right. If you're positive in the gram stain, phenotypic test. Kirby-Bauer. So we know we used Kirby-Bauer as like a tool for treating our patients. So if you're resistant to an antibiotic, we grow a lawn, we stamp it with the discs, and then we use that information to say we should treat with this antibiotic at this concentration. Some bacteria are resistant naturally to certain antibiotics. And if we say this person has an infection, And I think it is, I don't even know what, Acinetobacter, I don't even know. Acinetobacter, and Acinetobacter is usually resistant to streptomycin. Well, if we can grow it on a plate with streptomycin, if it's resistant, that supports us in thinking that it's Acinetobacter. Okay, so we don't always use Kirby Bauer to diagnose, but you can use it as a diagnostic tool for some cases. Phage typing. You guys remember what a phage is? It's a virus that infects bacteria. So if virus 843 infects only salmonella and your patient has diarrhea, we get a sample of their stool, we culture it, and we see if virus 843 infects your patient's stool sample culture. If it does, that patient has salmonella. If it doesn't, it's not salmonella. Maybe it's E. coli, I don't know. But they commonly use this for diagnosing salmonella, using phages that only infect salmonella. If it infects your patient sample, your patient has salmonella. That's phage typing. What type of bacteria do you have based on the phage? If it infects it, you have that type of bacteria. Phages only infect one species of bacteria, so that helps to remember that too. Okay. That's it for the phenotypic tests. All right. Yes. 2C is immunochromatography. So that's what we're getting into next, the immunologic tests. The immunologic tests rely on antibody antigen or immune responses, generally speaking. Oh, I left one out. That was the complement test. I hate the complement test. H, complement. Serology means we're using serum that has antibodies in it to see if you have a reaction based on antibody reaction. So if it depends on antibodies in the serum, we often call those tests serology tests, okay? Immunofluorescence. We have linked an antibody to something that fluoresces, like it glows green. So what I could do is, if I have an antibody that sees staph, and it only sees staph, and it fluoresces, I'll take your patient's throat swab, or I don't even know what, if it's staph, skin swab, put it on a slide, incubate it with my antibody, rinse it. If the antibody stays stuck, it's staph. Immunofluorescence. You'll see this a lot in your case studies too. They call it IFA. We can use antigen that's fluorescently linked, or we can use antibody that's fluorescently linked. Depends if you're direct or indirect. Okay. Immunochromatography. We have a piece of paper, filter paper. We put the sample on it and we let it run down the filter paper. If it interacts with the thing in the line and causes a color change based on whether the antibody or the antigen is there, that's immunochromatography. Home COVID tests. We have an antibody there. If the person has the antigen, it interacts, causes a color change, and you see a line. Immunochromatography. Chroma means color. Yes. That's exactly like a pregnancy test. So we have an antibody that's in a pregnancy test that if it sees the antigen, which is HCG, human chorionic gonadotropin, if it sees that, it'll change the color. It's the exact same mindset though. Okay, immunochromatography. ELISA, we've learned it. If you have a color change in a well, the antibody is there, or a color change in the well means the antigen is there, depending on what you're testing for. Okay. Linked to enzymes causing that color change. Titer is a measure of the strength of that color change. How much antibody is there? It's usually done by ELISA. Let's say that your patient has a positive ELISA. And you're like, I'm not so sure. This patient isn't seeing any signs or symptoms of this disease. Why would they have this disease? Maybe you want to be more specific. So now you take their sample and you run it out in a gel to separate all of the proteins in their sample. And you know that if they're positive, then that protein should be this size. And then you can take that separated protein sample, use an antibody to see if the protein is at the right size. And if it is, that more specifically tells you you are reacting with the right protein. Separating it on the gel and then using a filter paper to transfer it to filter paper and then seeing if that protein is on a filter paper. That's called a Western blot. I know it's an explanation. I'll draw it really quickly because I don't want to take too much more time on it. Exactly, this should look like the DNA thing, right? You put your sample in the well, you run it out with electricity, and you spread out all the different proteins. Then you transfer this onto a filter paper. The filter paper now has the proteins on it. Whatever, it's fine. And then you use an antibody that binds to your protein of interest if it's there and it's at the right size, it's where it's supposed to be, and it binds. It's more specific than just seeing if it's positive or negative in the ELISA. The ELISA might depend on the antibody interaction, but there's sometimes, very rarely, but sometimes, crossover with how the antibody interacts with things. You really want it to be very specific, then we'll reach for the Western blot as a confirmatory test. Okay, the Western blot. All right. Complement assay. This is relying on antibody-antigen interaction. If the antibody interacts with an antigen, then it keeps the antibody from interacting with blood cells and lysing them. So if the person has the antigen, the antibodies won't interact with the blood cells and lyse them. Same thing if we went the other way. If the person has the antibody, then it won't interact with the antibody. Let me just show you the picture of it, shall we? Bear with me here. We're going to get to all the way to complement. Virology, immunologic, indirect. I think it's the last one in the immunology ones. Immunofluorescence, ELISA, sandwich ELISA. Oh, there. If the person is positive, they have the antibody, it binds with the antigen, it doesn't lyse the red blood cells. If the person is negative, the antigen activates the complement, it lyses the red blood cells, and that's what you get. That's the idea of how complement assay works. I don't test about this one a lot. It is commonly used for diagnostics, but I feel like it confuses a lot of people on how it works. So I don't test a lot about the specifics. You should know that it is an immunologic test. That's about as much as I'm going to test you about it. Okay? And it relies on complement, the protein found naturally in the blood. Okay. There is a video of it, yes. And I think I play it on my recorded lecture. If you want to watch it, I can't click on it here. I was not smart enough to set that up, or I would play it for you. All right, tests like the PPD skin tests that are done in vivo. In vivo. So what does in vivo mean? In a living body. In vitro means in a test tube. It means in a fake place is what like the word really means, but like it means not in the body, okay? In situ. In situ means in the situation. It's kind of an in-between situation. What it means is if I take a breast cancer biopsy and I see if a probe binds with it, and it's still in the situation, it's still in the breast tissue, it's not fully all separated from the tissue itself. So it's kind of an in-between, in situ, okay? And then in utero is in uterus, and there's other ones that we can relate back to the terminology, the Latin terminology. But this is in vivo. The PPD skin test is done in your body. Most tests are done in vitro, right? Outside the body. Even getting your throat swab and run a PCR test, that's in vitro. We're not doing the test in your body, right? FYI. All right, so let's see what else. What was I at? Oh, yeah. Specificity and sensitivity. We learned about this back in chapter 13, right? It's back again. Okay, it will be on unit 3. Whatever you need to do to clarify the difference between specificity and sensitivity. Specificity, the more specific you are, the less false positives. Sensitivity, the more sensitive you are, the less false negatives. But you need to know what a false negative is or what a false positive is. A false positive is calling something positive falsely. That means you are saying it's positive, but it's not. The more specific you are, the less likely that is. The more sensitive you are, the less false negatives. False negative is saying something is negative when it's actually positive. So again, if it's actually positive and you call it negative, that's a false negative. More sensitive you are, the less likely that'll happen. Example of that was home COVID test is less sensitive than a PCR test. PCR test is very sensitive and more likely to be positive on the PCR test, right? Okay. What do you want your test to be? Specific or sensitive? It's a trick question. You want both. These are not mutually exclusive. That's on there. Okay, our genotypic methods, PCR, we've talked about it. It's amplifying DNA. If the primer recognizes the sequence, you will elongate. If the primer doesn't recognize the sequence, you're negative. You won't elongate. That's how it works. So those are nucleic acid amplification tests. They depend on PCR typically. Hybridization, using a probe. If your patient's, let me see. If the genetic sequence for staff, and the only reason I'm bringing it up is my student, I had a student that was showing somebody else's project to another student, and it talked about using nucleic acid hybridization. Nucleic acid hybridization. If the sequence for staff, the DNA sequence, is A, T, T, C, G, A, T, I don't know, I'm making it up. F. We'll make a probe that looks like that. And we can link this to a fluorescent marker. Maybe it's red. I know we labeled antibodies with fluorescent stuff earlier, didn't we? Yeah. If you have antibodies that recognize an antigen and it's fluorescently labeled, you'll glow from an antibody interaction. Here, we're talking about genetic sequences matching. This is depending on genetics here. So if this is the staff sequence, and I've made this sequence, and I've attached a red fluorescent probe to it, now I can take your patient's swab from their skin or whatever. Take their swab, put it on the slide. Now, this is the same exact result, but depending on genetic sequence. If the bacteria have this genetic sequence, TAAGC, TAAG, it'll match up and the probe will stick. You see how this is dependent on, it's almost the same thing, but depending on genetic sequence, not antibody-antigen interaction. We're tracking that? This, with using fluorescent probes, still using cells, they're still intact cells, which is in situ. They're still in their situation. We ain't ruptured them, they're fine, they're existing, they're still in their situation. Hybridization. FISH. That's fish. We can use this for diagnosing infections. We can also use this for diagnosing genetic anomalies. So if we're looking for a mutation in somebody's breast cancer sample, we can use a probe for that mutation. See, does this person's breast cancer sample, their biopsy, have this genetic mutation? If it glows, the probe stuck, they have the genetic mutation. We use this commonly for diagnostic testing for amniotic samples in pregnant women. See if there are genetic abnormalities, if there are predictors for that. We don't do amniocentesis unless it is called for. So if there's a predictor in there for a patient, then we might diagnose further using one of these tests like FISH. We can actually create a whole plate where here we have a genetic sequence for this type of breast cancer. Here is a different type of breast cancer. Here is another type of breast cancer. Here is a probe for another breast cancer. Here's one for a lung cancer. Here's another lung cancer. Here's a colon cancer, a colon cancer, a colon cancer, a colon cancer. And then I can take your patient's sample and wash it over all of this. And if it sticks to any of the spots, then I can say this person has these genetic abnormalities. They're prone to maybe having these types of cancers. On a big old card with a whole bunch of probes. This is called a microarray. I'm going to have like 360 different spots on it. Quite a lot. We can do mass exposure to a lot of different genetic sequences. We can do this for things like mutations, like with cancer mutations. We can also do it for different types of probes, for different genetic sequences, for different strains of bacteria. So sometimes it matters what strain of bacteria it is. If you have normal E. coli, you're going to have less severe illness, but if you have S-tech E. coli, which is Shiga toxin producing E. coli, Those are the ones that the news stories are always about: dysentery, bloody diarrhea, even death. So it matters sometimes. So you might need to know which strain of something it is. And we can use microarrays to identify stuff like that. All right, we can also do full genome sequencing of the genes of something and just learn everything about it that we can. That's useful if we have antibiotic resistance. We can learn as much about that organism as we can, about the entire genome sequence of it, and then use it for further studies and stuff like that. Okay, so that's the idea with the genotypic. Again, it's literally dependent on the ATCG sequence. If it's dependent on antibody or antigen, immunologic. If it's dependent on positive for a stain or negative for a stain, it fermented, it turned yellow, it made urease, and that's phenotypic. So this is really a chapter where you want to be sure you're getting your tests in the right categories, because often on the exam, I'll ask, which of the following are a phenotypic test? Which of the following is not an immunologic test? Those are common questions on unit 3. You'll see them again on unit 4 too. Okay? So this chapter should be pretty easy stuff. We only had a few new things on it. MALDI-TOF. I don't know if I have any pictures of it. This is our last one. MALDI-TOF, mass spec. In MALDI-TOF, this is mass spectrometry. So the results are depending on the mass of the molecules. What happens is we have a sample on a plate, and it's like your patient's swab of their throat. I don't know. Okay. This was the other thing, that paper or that presentation that I was showing another student as an example of a good presentation. It's in the one that's in your example, by the way, on the assignment. Now, that student talked about MRSA. They diagnosed the MRSA with MALDI-TOF and fish. I think it was fish. Okay. MALDI-TOF. Put the sample on a plate and it shoots a laser at it, and the pieces of the sample fly off. I know it's wild, okay? The pieces of the sample fly off, and then a detector measures how long from the moment the laser hit the sample to how long it took for it to get to the detector. And based on that, relates to the mass of the molecule and its parts. And then it creates spikes. And then based on the size of that molecule and how long it took to get to the detector and stuff like that, we can get the molecular makeup of whatever sample was on here, down to the atom. And how many carbons were in there, how many hydrogens. We had profiles of CHO groups. We had the breakdown of the molecule, and it'll give the time of flight for each part of that molecule. This is like physics type of chemistry, right? It's depending on the physics of the molecule. That's mass spec. So it's the molecular atomic breakdown of that molecule based on its physics. That's MALDI-TOF. It's super cool. There is a video for it. Again, I can't play it here because this is the type of readout that you'll get. You want me to read this to you and tell you what this means? I have no idea. I've never done it. I worked in a lab that did it, but I didn't do it myself. So cool stuff, I guess. But this would indicate to you what the exact molecular makeup is of that organism, of the sample, what the organism is, and how much of it there is in the sample as well.
Thank you.
I know, it's super cool. There is a video for it, and it does play on the recording of the lecture if you want to see it in your modules. I highly recommend it. I didn't put the link on here, or I'd play it for you. I didn't think about that because I wasn't smart enough. And then we have imaging. Who cares? You guys know what imaging is. You know what CT scans and MRIs and stuff like that is, okay? And that is it for chapter 18. Yes, it is. So we will now head up to the lab, and I'll see you guys up there in a minute or two. And we'll kick out the lab today. Should be pretty quick. All my other labs finished in under an hour. So good job today, guys.